systemic therapy option in metastatic castrate-resistant prostate cancer, and the presenter Alvydas Česas, medical oncologist from Klaipėda University Hospital. Please.
Okay, thank you very much for invitation for this very, very important event. But first of all, I would like to pass my great support to Ukraine and its people through this channel. Glory to the Ukrainians. Today I will focus, no discord, no conflicts. I will focus my presentation on two main topics. The first, chemotherapy for metastatic castrate-resistant prostate cancer, and second, sequencing of different treatment options in metastatic castrate-resistant prostate cancer. Treatment metastatic prostate cancer improved years by years. In 2004, docetaxel was the first agent to show significantly extend survival in hormone-resistant prostate cancer. In 2010, was approved cabazitaxel. This compound showed significantly extended survival in metastatic castrate-resistant prostate cancer. Many guidelines we use in everyday practice, ESMO, NCCN, European Association of Urology, and its support very, very important because we need to every day test and look to guidelines because very fast change every one treatment, not only in prostate cancer. First of all, we know historical data about efficacy docetaxel improving overall survival in metastatic castrate-resistant prostate cancer. Tarnok, Trilec, Oldart, Fossa shown additional valuable and profit in overall survival when we used docetaxel combined with estromustine, with prednisone, in another part, mitoxantrone or weekly docetaxel. At this moment, we know that docetaxel is one of the main chemotherapy compounds which used in treatment castrate-resistant prostate cancer, but now it's coming early in high-risk patient for hormone-sensitive prostate cancer. Of course, we know another taxane, cabazitaxel, which showed two additional benefit, but it's not enough for these days. Only two compounds. We must use all possibility effective treatment and this sequencing and look for new causes of resistance to existing therapies. I would like to present case incorporating in my presentation. A man, 59 years old, no bad habits. In November 2018, was diagnosed prostate cancer, Gleason 3.47, G2, T, clinical T2C, and 0, and not perform bone scan at the present moment because this patient was operated in another hospital, not university hospital. Initial PSA 9.7, MRI showed local disease. Radical prostatectomy with blood and neck reconstruction and bilateral perilateral lymphadenectomy were performed. Stage 4, PT3 and 0 M1. Solitary metastasis in the bladder, 80% prostate lobe involved. R1 resection in G2. In January 2018, after our MDT confirmed treatment plan, was started ADT, applied external radiation therapy, to grade 33 fraction doses, summer doses 66 gray into prostate lesion and seminal vesicle area. And the docetaxel chemo was initiated in combination with ADT based on high risk. The 6 courses of chemotherapy were realized and ADT was continued. In September 2020, increased PSA until 5.1, but for correctly, I would like to add that PSA not drop down until 0, only 0.2. Bone scan, complete body CT revealed multiple sclerotic metastases of bone and para-aortic lymph nodes. In October 2020, started treatment on ADT and enzalutamide. You can see lymph nodes enlarged and bone additional sclerotic metastases. As we know, the survival benefit associated with docetaxel early in the course of treatment, particularly in men with high volume metastatic disease, are substantially larger than the survival benefit association with using docetaxel later after castration-resistant has developed. Its important issue means that chemotherapy still works in prostate cancer, but we need to know what exactly plays chemotherapy and what is the right patient for chemotherapy. In this diagram, you can see many possibilities. In first line, before docetaxel, enzo, and abiraterone. Later, docetaxel, and possibility abiraterone after docetaxel and cabazitaxel, enzalutamide too. We can incorporate radium-223 because this treatment modality is more confirmed that if we have symptomatic disease. And together we can treat zoledronic and denosumab because time for first skeletal events, median overall survival increase in this endpoint. Several agents approved for metastatic castrate-resistant prostate cancer, but optimal sequence is unclear. No comparison treatment, new agent with current standard therapy. Some new companies afraid this decision for new clinical trials. Best treatment option after docetaxel and one line of novel endocrine agent unknown. Unmet medical needs. Should we switch to ART? Should we use cytotoxic after ART? And what is their possibility to third line for trials for good conditioned patients? Prostate cancer is heterogeneous with coexistence of androgen receptor dependent and androgen receptor independent tumor cells. You can see androgen receptor negative cells and positive cells. And of course, we know additional group and neuroendocrine differentiate prostate cancer and adenocarcinoma. And we need to think about that. If no additional benefit for androgen receptor target therapies, we need to think maybe it's mutation, some androgen receptors, and we should test maybe we have mixed features of neuroendocrine prostate cancer and prostate adenocarcinoma. Primary resistance to ARTAS and PSA changes we know. Unfortunately, alpha androgen receptor antagonists have provided benefit to many, but not to all patients responded to therapy. And among those who do, the durability of response is often limited. You can see in this diagram, if after starting treatment, after 12 weeks, we have no response on PSA, we should thinking maybe it's primary resistant of ARTA therapies. If we need to, or maybe a biopsy for confirmation, maybe neuroendocrine differentiation, or maybe need to start chemotherapy immediately. Primary resistance, it's not new news in androgen receptor target agents. In main phase 3 trials AFRIM in SOAA301 confirmed primary resistant one of 3 patients, in AFRIM one of 4 patients, because after 3 months we can see that resistance in all treatment with ART was not effective. And we know from phase 3 trial, both trials showed that we need to test PCI level and experience immediately progression of disease from these androgen receptor target agents. Antonarakis hypothesized that this primary resistance may plausibly be due to the presence of androgen receptor splice variant. Potential mechanism of resistance to ART, it's a big dilemma at this moment, because it belongs a lot of resistant mechanism, steroidogenesis upregulation, crosstalk, activation alteration, oncogenic signaling, epigenetic alteration, linear modification, splicing variants, RA mutations, R amplifications, and a lot of this method. Some publication author perform non-systematic review of the literature from 2004 to August 2016 by searching in Medline. Genomic characterization of liquid biopsies such as circulating tumor cells, circulating DNA, and circulating RNA are non-invasive tools to future personalized treatment in prostate cancer. Let's go back to case one. The response to enzalutamide therapy was approximately 12 months, a little bit less. The patient's general condition, pain, chronic fatigue, weakness, ability to work worsened. SOG from 0 now was in SOG 2. Beside oblique time, 6 months. RADIS 2 to 3 was not indicated due large visceral metastasis, and patient was enrolled in clinical trial in which abiraterone acetate was administered after progression on enzalutamide, and discontinued in September 2021. Treatment was continued for a total 2.5 months and discontinued in December 2021 due to general deterioration. And what it mean that ART and another ART it doesn't work. You can see a CT scan, bone progression. How it's possible to confirm cross resistance between ARTs? It's tested a lot of, but not very large, but smaller trials from 2013 until 2015. And show the duration of second treatment, it's very, very short, approximately 3 months, not more. And PSA, 50% PSA decline, we've seen only from 3 until 20%, not more. And median PFS, 2.7 until 6 months, and maybe need to use ART therapies in sequential setting. It's very, very, very rare cases. As of today, our knowledge of treatment of sequencing in M1 castrate-resistant prostate cancer was based on retrospective data, and no very good data for showing that it's possible to use ARTA and ARTA and do supporting mechanism of cross resistance. And return to chemotherapy. Chemotherapy still works in 2022, where we are. And as we know, cabazitaxel in one of Taxane's compound, rotate activity post-ARTA and post-docetaxel, doesn't matter. Cabazitaxel active after docetaxel and abiraterone. PSA response more than 50%, ranged approximately 40%. PFS due progression, it's for 4 and for 6 months, but overall survival increase until 16 months. Cabazitaxel active against enzalutamide or are abiraterone sensitive and resistant cells. On the right hand, you can see how many patients PCR response with cabazitaxel post docetaxel and post abiraterone. It's only few patients not responding by PCR in this area. All NACUs reported no collateral resistance to cabazitaxel in enzalutamide-resistant tumors, and no collateral resistance in cabazitaxel-resistant cells to abiraterone or enzalutamide. And you can see prior art does not affect inactivity of cabazitaxel in men with metastatic castrate-resistant prostate. One source from Netherlands study showed that prior treatment with ART may not influence the efficacy of cabazitaxel in men with castrate-resistant metastatic castrate-resistant prostate cancer. With emerging evidence of cross-resistance in the treatment of metastatic castrate-resistant prostate cancer, cabazitaxel provide a good treatment option irrespective of prior ART. Retrospective sequencing studies. Sequencing included docetaxel, cabazitaxel, and ART seems to provide greatest benefit. Suggests that cabazitaxel retains activity across treatment lines. It was approved. Overall survival in FLAX trial appears to increase with the number of life-extending therapies, with a sequencing including docetaxel, cabazitaxel, and ART providing the greatest overall survival benefit, ranging from 40 and 60 months in metastatic castrate-resistant prostate cancer. And FLAG trials showed that factor influencing overall survival in multivariate analysis showed the response to first ADT less than 20 months, Gleason score 8 to 10, clinical progression, and high percent specific antigen level at metastatic castrate-resistant prostate cancer diagnosis were associated with worse overall survival. Prior receipt of ART did not influence activity of CABA. In another trial, Plato, we can see PFS if progression after enzalutamide, we added abiraterone. It's not worse. There was no difference in secondary endpoints. Combining enzalutamide with abiraterone acetate and prednisone is not indicated after PSA progression during treatment with enzalutamide alone. And the conclusion in this trial, Plato did not meet its primary endpoint, PFS, not additional value. Combining enzalutamide with abiraterone is not indicated after PSA progression during treatment with enzalutamide monotherapy. There was no clear superiority of any one of these three strategies. You can see 13 retrospective studies post docetaxel in metastatic castrate-resistant prostate cancer. More than 1,000 patients was involved in this systematic review presented in 2015 on mains. But sequencing that included CABA to suggest a possibility over a survival advantage. Cabazitaxel and ARTA combination is most effective with prolongation life, and 12 months alive, 76%, comparison to ARTA-CAB in next line, 61, and the combination 2 ARTA therapies, target agents, androgen receptor, it's only 28%. Dose CABA and 1 ARTA associated with the best survival. I would like to show the CAR trial, which was presented in Barcelona, ESMO Congress 2018. The efficacy and safety of cabazitaxel as comparing with androgen signaling target inhibitors, abiraterone or enzalutamide, in patients with metastatic castration-resistant prostate cancer who were previously treated with docetaxel and had progression within 12 months while receiving the alternative inhibitor, abi or enzalutamide, are unclear. Published in the New England Journal of Cancer. And now I would like to return again to our case. In November 2021, body CT scans, PET-CT showed significant progression of disease. Grade 3 weakness and pain on the WAS scale was 8.9. It's pain was very, very huge. SAOG2, anemia grade 2. In December 2021, started chemotherapy with cabazitaxel. You can see all dynamics of CT scans and enlarge and progression in 2021 in November, in big masses in the aortic and pelvic areas. There you have, you can see PCA dynamic during all treatment. After radical prostatectomy, ADT, radiotherapy, and docetaxel, you can see a dropping PCA level until 0 to 2. But it's last one. It's nadir in on primary therapies. But after practice 6 months, PCA doubling time, additional started treatment with ADT with enzalutamide. And you can see a very good drop until 0.04 and continue approximately 6 or 7 months. And after that, the doubling time during 6 months was presented, and the patient was involved in clinical trial with abiraterone acetate, but dramatically progressed disease during 2 months until started treatment cabazitaxel. Its PSA level increased until 53.74. And after treatment, first course of docetaxel dramatically dropped PCI level. What does it mean? It means that every one therapist changed PCI levels, but not in this direction. ADT, ENZA, ADT, abiraterone acetate. What does it mean? It means that we not need to use the same mechanism of efficacy treatment. You can see progression in the bones and a lot of many other. And go back to the study. You can see study design patient with one castrate-resistant prostate cancer who progressed less than 12 months on prior alternative therapy before or after. Involved 255%, good performance status from 0 to 2, time progression on prior alternative therapy from 0.6 and 6 to 12, and timing of before or after docetaxel. And patient received CABE or abiraterone and enzalutamide in standard dose. Endpoint primary radiological progression-free survival, and key secondary overall survival, progression-free survival, PCR response, and tumor response. Eligibility criteria: histology confirmed metastatic castrate-resistant prostate cancer, at least 3 cycles of prior docetaxel before or after ARTA. Progressive disease less than 12 months on prior alternative ARTA. Docetaxel abiraterone in metastatic and hormone-sensitive prostate cancer allowed. ACOG performance less or equal to, score 2 only allowed if related to prostate cancer. PCR value more than 2 nanogram per milliliter to study entry. Serum testosterone level less than 0.5 nanogram milliliter. Adequate organ and bone marrow. And you can see patient heredity. It's very good balance. Many patients more than 75. It's approximately 30%. And PCA level, type of progression and pain, plus PCA and radiology in 66 and 71% in ARTA group. And prior alternative ARTA, you can see it's a very good balance. Abiraterone Enza 43, 55, received before after docetaxel 38. It's very good. And the median duration of prior alternative ARTA, it's 77.6 months and 8 months. Radiographic progression-free survival was primary endpoint, and the median imaging-based progression-free survival was 8 months with cabozitaxel and 3.7 months with the androgen signaling target inhibitors. All subgroups show better efficacy than other ARTA. Overall survival, key secondary endpoints was 30.6 months with cabozitaxel and 11 months with the androgen signaling target inhibitors. P-value 0.0078. It's statistically significant. Response definition, PSA tumor and pain response. It's very important. PSA reduction more than 50% from baseline, confirmed by a second value at least 3 weeks later. Tumor complete or partial response according to RECIST 1.1 criteria. Pain decrease more than 30% from baseline in average BPASF pain intensity score at 2 consecutive evaluation 3 weeks apart without increase in analgesic user score. You can see in all endpoints was objective and statistically better response. Time to symptomatic skeletal events, occurrence of new symptomatic pathological fracture, or use ARBT to relieve bone pain, or occurrence of spinal cord compression, or tumor-related orthopedic surgical intervention, much better in cabozitaxel group and not reach at cutoff. For safety, it's, as we know, cabozitaxel in chemotherapy compound, and we're afraid and very scared for start treatment with chemotherapy. But as you see in this slide, you can see serious adverse event is the same for all groups, CABI or ARTA. Any grades more than 3, grade 3 adverse events, little bit high in cabozitaxel, but 56 and 52. Adverse event leading to treatment discontinuation 2 times higher than ARTA group. Of course, it's tablets, it's not chemo. But adverse event leading to death, it's 2 times less in cabozitaxel than in ARTA group. Of course, mainly it's febrile neutropenia, but only 3.5%. And of course, we know that we have very good equipment for prevention of febrile neutropenia with granulocyte colony stimulating factors. And cardiac disorder is much higher in aorta groups, and because we have old patients, and 30% was older than 75 years, and main grade 3 adverse events, adverse events was very few cases in cabazitaxel, but in aorta groups it's 6 cases. First sequential anti-cancer treatment, it's cabazitaxel was first in a group of aorta, and palliative radiation therapy in aorta groups was next treatment possibilities, but in cabazitaxel only for 7. To meet other type of metastatic castrate-resistant prostate cancer, we use a lot of NCCN suggestions, and you can see primary treatment, chemotherapy, no prior docetaxel, no prior novel primary treatment, AB, dose, and zolitomy category 1. If we have another type, use circumstance in metastatic castrate-resistant prostate cancer and HRR mutation category or BRCA mutation category, we should use medicines like PARP inhibitors, olaparib or rucaparib, and of course we can try to use carboplatin. In MSI high, mismatch repair deficiency or tumor mutation burden more than 10 mutations per megabase, we can treat a patient with pembrolizumab. And prior docetaxel, no prior hormonal therapy, it's possibility to involve the metoxantrone. It's not very popular. Cipollotel T in Europe, but in the US it's used very often. And it doesn't matter what line, if we have HRR mutation or BRCA mutation, we can use olaparib or rucaparib. In area small cell neuroendocrine prostate cancer, we should use and start treatment immediately with cisplatin, etoposide, carboplatin, etoposide, docetaxel, carboplatin, and cabazitaxel, carboplatin. Let's return to our case. In December 2021, started chemotherapy with CABE. CABE improved overall condition. Pain by WAS scale decreased until 2, fatigue grade 1. The patient returned to his regular job as a welder. PSA response after 2 cycles of chemotherapy, 6 weeks, more than 50%, from 53.7 until 18.7. In conclusion, in this case, we need to carefully select patient for the right therapy at the right time, and the reuse of another ADT after progression with another ADA should not be continued. And overall conclusion. As we know, CAR trial met primary objective. Cabazitaxel more than doubled radiological progression-free survival versus AVE and ENZO. Cabazitaxel reduced the risk of death 36% versus Aberton and enzalutamide. In a significantly improved number of clinical outcomes and compared with androgen signaling target inhibitors. And we need to treat patients with metastatic castrate-resistant cancer who have been previously treated with docetaxel and alternative androgen signaling target should start treatment with cabazitaxel. Prostate cancer is highly heterogeneous. Danger is directly comparing phase 3 trials. Level 1 evidence for cross-resistance between ARTA, it's not ATA, ARTA, or chemotherapy. Both are needed. Chemotherapy is still on the way. Radium-223 for symptomatic bone metastasis category 1. But we note very carefully if we would like to continue another treatment, especially of chemotherapy, do myelosuppression. Olaparib can be considered after new hormonal agent for patients with metastatic castrate-resistant prostate cancer with alteration in BRCA1 or BRCA2. Pembrolizumab for MSI high mismatch repair deficiency or tumor mutation burden more than 10 mutation for per megabase, and we need to read the guidelines. In discussion, androgen receptor splice variant 7 detected in circulating tumor cells in prognostic in castrate-resistant prostate cancer. Splice variant 7 positive patients are less likely to respond to abiraterone and enzalutamide than negative for splicing variants. While androgen receptor splicing variant status does not seem to affect the response to taxanes. Prevalence of androgen receptor V7 splicing variants is low before treatment, but increasing with sequencing therapy line. Consider tumor testing for homologic recombination genes and mismatch repair defects or microsatellite instability in patients with metastatic castrate-resistant prostate cancer. Approximately 20% of metastatic prostate cancer harbor aberration in genes involved in DNA damage and repair. DDR and BRCA2 is the most commonly altered. Substantial proportion of these aberrations are also present in germline. Prostate tumors related to germline BRCA2 mutations often have Gleason score more than 8, nodal and distant metastasis at diagnosis. Germline mutation and BRCA2 have been associated with poor clinical outcome across different disease states. 30% of metastatic prostate cancer patients found to carry a germline DDR mutation did not have previously had family history of cancer. Thank you very much for your.
Thank you very much, Dr. Česas, for sharing of news in therapy fields. And we have some questions for you, please.
Jolita Sadauskienė, medical oncologist from National Cancer Institute. I would like to ask you, do you use chemotherapy combination cabazitaxel with carboplatin in your everyday clinical practice? And if yes, is it important for you BRCA status of patient? Thank you.
Thank you very much. At this moment, we not use routinely this combination because we don't have reimbursement, but we not have indication at this moment for cabazitaxel combination therapies. It's possible to use only in very, very rare cases. But in what is the main now need to work and do, it's reimbursement of olaparib, rucaparib for BRCA mutated metastatic castrate-resistant patient. We need to involve the PARP inhibitor in our daily practice as soon as possible because approximately 20-30% of all metastatic castrate-resistant prostate patients, maybe a little bit younger patients, have this mutation or HRR mutations. We need to incorporate this immediately, this treatment modality, because all guidelines, ESMO, European Urology Association, NCCN, show that it works. We need to prolong as well, and sequencing chemo, combination chemo, PARP inhibitor, other therapies. We need to use for every patient, but not select patient for who can pay himself.
But PARP inhibitors are not reimbursed in Lithuania yet. And then what about carboplatin monotherapy in BRCA mutated patients?
Yeah, it's good question, but we use in BRCA patients because if not possibility to prescribe olaparib in this case, we some cases we use carboplatin monotherapy because after dose carbo it's not another possibilities.
Thank you.